Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Today, the future of the HIV epidemic in the United States. Jeremiah Johnson is a longtime HIV advocate and the director of PrEP4All, an organization that supports more resources for HIV prevention. He speaks to Dr. Josh Sharfstein about the nation at a crossroads with HIV, with the opportunity to end the epidemic and the alternative that it could get a lot worse. Let's listen.
Jeremiah Johnson, thanks so much for coming to Public Health on Call. How are you doing today?
I'm doing fine. How are you doing, Josh?
I'm doing fine. I'm looking forward to this conversation. I'm familiar with your work calling for more HIV prevention in the United States. Could you tell our audience about your organization?
Sure. So I'm the executive director at PrEP4All. And as you said, we focus a lot on advocacy and policy advocacy related to HIV prevention, and specifically pre-exposure prophylaxis, or PrEP, which, if you're not familiar with that, is the use of antiretroviral medications. There are certain regimens that have been approved by the FDA to prevent acquisition of HIV for people who are HIV negative. And we've been really focused, and since our founding in 2018, to get more equitable access to this important intervention.
Now, some people may be listening and wondering, well, what is the state of the HIV epidemic right now in the United States?
So I would say that there have been some hopeful signs in recent years in terms of driving down new HIV infections. We've been hovering for a while at around 35,000 new infections every year. We've seen a slight downtick in recent CDC surveillance around that. But the reality is that we can choose sort of one of two pathways right now. We could either scale up these great tools that we have. We've got, including a new injectable version that can be injected once every 6 months, which is, we don't toss around the term vaccine with it because it's not a vaccine. But in terms of that same concept of a long-acting intervention, could be something really hopeful in the toolkit. We've also got the proof that when you get those of us living with HIV onto treatment, that you can stop onward transmission of HIV, a concept known as undetectable equals untransmittable, or U equals U. If we invest in that, we're in a place where we could end HIV as an epidemic, but it's also precarious. And so there are also signs that if we let up on the gas right now, we could start to see us going in the opposite direction. So it's really a moment where it depends on what sort of pathway we choose as a nation.
That is such a vivid explanation. We've sort of been plateaued, maybe doing a little bit better over time, but that could turn in either direction.
Absolutely. And, this is something that is relevant to a great many Americans. About 1.2 million Americans are living with HIV all over the country. And those people have loved ones and friends who care about them. So this very much matters to a great many Americans. Also, the CDC has estimated that around 2.2 million Americans are in need of PrEP access. That's actually gone up from an original analysis of 1.2 million. So, not an unmanageable problem per se if we keep the foot on the accelerator, but could be a real problem for a lot of Americans if we turn a different direction.
And let me just ask you about the finances. Not that that's the first question to ask, but I'm curious, these two different directions, do they have different fiscal implications for the country?
Absolutely. Advocates often talk about CDC estimates that the average lifetime cost for a new HIV infection in current US dollars is around $500,000. For a reasonable public investment, you could easily get, 5,000 or 6,000 individuals onto PrEP for the cost of just one averted HIV infection. So, it's one of these things where when we hear about cutting costs for investment in HIV right now, it may at first sound like something that is fiscally responsible, but it's really stepping over quarters to pick up pennies.
Interesting. So if we could shut down the transmission of a potentially lethal infectious disease, there's a lot of savings compared to letting it spread.
That really is the case. It may sound upfront to be wise to cut the costs for investing in more firemen in your community until there's a fire everywhere, and then it's much more costly. It's not really that different of a concept.
Thank you. So let's talk about what matters to turn that curve down instead of letting that curve go up. What would be one thing on your list?
So the bedrock of almost any sort of important public health intervention for infectious disease is testing. And in HIV, that's certainly the case. And a lot of testing that happens in America, certainly if you go to your doctor's office, we're hoping that they're offering it to you. But a lot of important testing, particularly in communities where we really need to have greater surveillance, happens because of CDC funding. And that agency in particular is essential for getting out there, getting tests into communities. And speaking of surveillance, it also gives us some visualization into the dynamics of the epidemic. So, we're never going to be able to have enough resources to be everywhere all at once. That helps us really understand where to invest and make sure that we're scaling up interventions. Once you have a knowledge of how many people are living with HIV in a community or are at risk for HIV in a community.
How is the testing effort going?
So, we have made some great strides in America around that. I believe the last figure I saw was that only about 15% of those living with HIV in the country don't know that they have HIV. And that's actually, not terrible. It could always be better, and we need to continue to do that. We've also seen some amazing innovations in recent years, like the Together Take Me Home initiative from CDC, which has gotten, I want to say 1 million tests, at-home tests for people in order to identify a number of people who otherwise have never gotten HIV tests before and didn't know that they were HIV positive. So that direction's been going in a good way. The challenge right now is that we're seeing a lot of uncertainty about that funding going forward, and the divisions that oversee those initiatives are experiencing a lot of uncertainty, possibly going away or being dramatically altered. And so we have a lot of concerns about what's happening right now.
In other words, concerns that the CDC funding that's been supporting this testing and the expertise that's been guiding this testing may not be there, which could lead to less testing and a lack of visibility of what's happening with the epidemic.
Exactly. And the thing is again, you're working with communities that often don't have the best relationship with sort of organized systems and public health systems. So, many times the expertise that you have in these offices, it's not just about the nuts and bolts of testing. It's a trust-built relationship with community leaders and an understanding of how to get out there and really access communities. And that's something that once that goes away, it can take a very long time and maybe impossible to replicate.
All right, so we've talked about testing. What else is on your list as a really important factor about whether we're going to go down in HIV or we're going to go up and see a lot more infections?
So, I'm going to lean into my preferred, topic, which is going to be PrEP, of course. And there's been some really compelling research that's come out of Emory University that has shown, that districts in the U.S. that have scaled up PrEP access have seen significant declines in new HIV diagnoses year on year, to where communities that haven't scaled up PrEP, we haven't been able to see that same reduction. As a matter of fact, oftentimes you continue to see an increase in new diagnoses. And so that's where we've been particularly focused on how can we help communities do better to get PrEP out, particularly with communities that are oftentimes being left behind. We know that white individuals, cisgender men, they are more likely right now to gain access compared to, say, Black cisgender women that need access, people who inject drugs, communities that have been affected by the opioid epidemic. or communities of color. So in particular, to smooth out all of those inconsistencies, one, advocates have been fighting to try and facilitate coverage for insured populations. And so there's been a lot of advocacy related to the Affordable Care Act, protecting the provisions there, making sure that they're enforced well, but also making sure that and underinsured populations aren't left behind in terms of all of this. And that's where we've been calling for a national PrEP program. You're obviously very familiar with that since we co-wrote a proposal around that back in 2021. But that would ideally really facilitate the cost and coverage barriers that many of those communities face, smooth out any sort of patchwork issues there, and address just other simultaneous barriers that people experience in terms of PrEP access.
Right. So the more people can get access to medication that prevents infection, the fewer infections there'll be. How is it going right now? We haven't talked in a little while, so I asked that somewhat hesitantly, but like knowing we did have a vision that if people could get access to those medicines, we'd see a lot fewer infections, and other countries have really proven that. How's it going in the United States?
So part of that is a bit of a question right now, just because we don't have very recent surveillance from the CDC in terms of PrEP scale up. Some of that was that the CDC was changing some methodology in terms of that, so we were already experiencing a delay. Now, due to funding cuts, we're also experiencing further delays in terms of getting that data out there. But indications seem to be that the absolute number of PrEP prescriptions is headed up. And so we are hopefully seeing, 400,000, 500,000 individuals on PrEP access in the U.S. The problem is that we're not seeing a lot of progress in addressing those disparities. And so, if we don't have interventions that are built and sustained that help reduce those disparities, we're going to continue to see a situation where we see new HIV infections going down for white communities, for male communities, and not so much for communities of color. You'll continue to see it more in cities than you see it in rural areas. And that's going to be a real shame when we have tools that could be doing something so much better for everybody.
Jeremiah, I've heard that some research into how to increase the use of PrEP in rural areas has been canceled, and that studies on how to overcome these disparities between groups in order to reduce the overall number of HIV infections have been canceled. How concerned are you about those developments?
I will say there's a certain amount of confusion. So, for example, I've been involved in a really interesting study looking at over-the-counter PrEP, and they first received a cancellation notice for their NIH-funded study. That was just reinstated. So I will just put the caveat in there that I think there's a lot of close monitoring. But the reality is again, when you have these interruptions, some of these studies, they don't just pick right back up. And I do worry about a chill on innovation. I also worry that an uncertain application of scrutiny related to certain key populations, because it is related to concepts of diversity, equity, and inclusion, leaves a lot of people very confused. Some of these grants were canceled simply because they had a word within them that pertained to populations that are being scrutinized right now. That's not a great way to do science, and it's certainly going to make it harder for any community that we're trying to research addressing disparities in PrEP access within.
Let's talk about treatment, maybe as our last topic. You mentioned
Sure.
that really important step in reducing HIV infections is making sure that people who do have HIV can be effectively treated. What are you thinking about the prospects there?
So there are a lot of concerns right now. And I think it's important to note that the U.S., has been stuck for some time. We're maybe getting around 2/3 of people who are diagnosed as living with HIV to undetectable or successful virologic suppression. But when you factor in the undiagnosed population, it's only about 50%. We need to be doing much better. Now, the Ryan White HIV/AIDS program has some excellent figures in terms of how well they're getting individuals to viral suppression. And it's really the cornerstone sort of safety net program. Right now, though, the concern is particularly if a number of individuals fall off of Medicaid, which is the number one insurer of people living with HIV in the US, that we're going to start to see people within that system putting more of a strain on Ryan White and overall creating a burden on the system that could lead to wait lists for HIV treatment going forward and different shortages that are going to cause us to really backtrack. We could continue to make progress, but right now I'm not sure if we're going to.
So more testing, more prevention, more treatment. That's the recipe to bend the curve down, but it sounds like there's some clouds on the horizon.
It's true. And the last thing I'll just say is, in the background of all of those are those socioeconomic aspects for individuals. And so, it's not just simply medications and, testing kits and everything getting out there. We do need a certain level of tailoring of getting these interventions into communities that need them the most. And that's a holistic response that I am worried will that continue to be embraced going forward in terms of HIV prevention, testing, and treatment.
Jeremiah Johnson, this has been such a great conversation. It's always great to see you. Thank you for joining me.
Thanks for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.